Okay, welcome to another podcast, another Complete Physio podcast. We're joined again by Mr. Simon Moyes. Simon, many thanks for joining us. We did a previous podcast about meniscal injuries, which is very interesting. And I've seen lots of patients that have found that very useful. Yeah. And today we're going to talk about ankle sprains.
Yes.
And we wanted to do this because we're seeing so many patients at the moment that aren't getting the optimal management. So do you just want to go through a sort of classic scenario that we see with patients with ankle problems and how they end up sort of seeing you?
Yes. So what happens is people roll their ankles or go over on the ankles or invert their ankles incredibly commonly.
And so that is when you roll onto the outside.
And it probably happens in 1 in 10,000 or 1 in 15,000 people per day roll their ankles. So it's the commonest MSK injury us as orthopaedic surgeons and probably you as physios see.
So since you started that sentence, somebody's probably done it.
Oh God, thousands. Yeah. Thousands globally, 9 billion and growing, isn't it? So yes. So what happens is at the moment, someone's playing football, falls down the stairs, whatever, they roll their ankle. There's a ghastly sort of twisting movement. Often there's a nauseating pain. They often experience a snap or a pop, and that can be a small bone breaking, it can be a ligament tearing, or it can be a tendon partially tearing, or any combination of the above. Quite rapidly, the ankle will swell, often within minutes, if not within hours. Patients then find it typically very hard to weight bear. They normally then drag themselves to an A&E department, or sometimes they're lucky an urgent care department in the private sector. They then get typically x-rayed only. It may be that someone fairly junior may look at those x-rays and then they'll then normally be told there's no significant fracture there. And then they're effectively discharged from care and told either to wait for an orthopaedic outpatient appointment if they've got persisting symptoms or to contact their GP. And then typically after a few weeks, they come up and see either you or me with a problematic ankle. And here we are, we've got a patient a few weeks down the line. They've got a painful, swollen, stiff ankle and hindfoot without any definitive diagnosis being made. And they've just been told there's no significant fracture. And that's what we see an awful lot of.
Yeah. So let's go back a few stages there. So if you're a patient, you go to A&E, you get assessed by somebody. Not always do you get assessed by a musculoskeletal expert.
True.
So somebody that sort of sees everything, more of a generalist than somebody that sees lots of these problems. And I think for somebody watching this, the first thing is to make it clear that x-rays don't show all breaks. And when we say fracture, we mean a break, or a break of the bone. So do you just want to talk through, like, how do we miss these fractures on x-ray? Surely a x-ray shows every break.
So only significantly large fractures, I think it's more than 1 or 2 millimeters, will actually show up on a fracture. So hairline or undisplaced fractures won't often be seen on plain films. The films won't see soft tissue injuries like tendon injuries, ligament tears. They won't see bad bone bruising, for example. So, really, in order to get a definitive diagnosis, you need an MRI scan. And as you know, ultrasound scans can also pick up a lot of injuries. They'll pick up in the ankle and hindfoot. They'll pick up lateral ligament tears, Achilles tendon injuries. They'll pick up peroneal tendon tears. So, further imaging is required.
Yeah. And so let's be clear. So x-rays don't always pick up breaks, but I suppose what we need to be aware of is that not everybody can get an MRI, and certainly, A&E departments are going to struggle to get MRIs for people.
Certainly within the time frame they're needed, yes.
So I think if and obviously if you've got private healthcare and you can afford private healthcare, then we would strongly advise that you go and see an expert as soon as possible to get the right imaging. Don't delay.
Yes.
Because although that x-ray may be considered normal, we still know that you could have a broken bone.
Yes.
But actually, I think the thing people forget about is that actually a broken bone heals very well. It's really not the end of the world most of the time. And bones heal 4, 6, 8 weeks, they're healed. The problem is that's almost classified as the worst injury. But from our experience, a ligament injury, a tendon injury specifically, can actually take a lot longer than that. And we don't know anything about that when they have an X-ray done.
Yeah, so of all the things you can injure as you invert your ankle, from the fibula here to the lateral ligaments here, to the peroneal tendons, to the cuboid, to the os calcis, to the base of the fifth metatarsal, any of those structures can be injured, or any combination of those injuries.
Yeah.
But the commonest subgroup is when people tear their lateral ligaments. And as when you hear someone saying, I've got an unstable ankle, or I've turned my ankle and damaged the ligaments, it's the lateral ligaments that get damaged. And when they're torn, they're completely torn. And there are 3 grades of injuries, as you know. But a grade 3 is when the ligaments have been completely torn, like pulling 2 horses' tails apart. The ankle is unstable. Yeah. And patients need to be immobilized, ideally within the first few days of sustaining that injury. Otherwise, the swelling means that the ligaments heal too long. So if they're not immobilized in the right position with the ankle in neutral, in a proper boot, then there's a high chance that the ligaments won't heal properly. And that's sadly when you and I see them. Yeah. So they often rock up in my clinic 3, 4, 5, 6 weeks down the line.
Still getting pain.
They're saying, my ankle's swollen, it hurts, it clicks, it feels weak and unstable. I examine them and I say, I'm sorry, but your ankle ligaments are now unstable.
Okay. Now, what do you mean by unstable? Because that's really, if you end up with an unstable ankle, that's where all the long-term problems can start, isn't it? Yeah. So what do you mean by an unstable? What would somebody feel if...
So an unstable ankle is when your ankle typically is painful still at the site of the injury. The ankle feels like it's moving too much. It feels weak. It feels as if it could collapse on you. So typically people will struggle to get back into their heels, for example. They'll struggle going downstairs. They'll struggle on uneven ground like sort of cobblestones. And they certainly won't want to get back to their sports, which involve running and twisting.
So it's a sensation that a patient gets, isn't it? That they feel weak, vulnerable, like they're just going to go over on it again. Yeah. And that could be an indication that their ligaments are no longer functioning the way they should.
Exactly.
And those are the ones that we think can have long-term problems.
And you and I have tests for them. So the clinical test, when we assess a patient in clinic, is we look at the patient, the ankle's typically swollen, the patients are typically tend to hear over where the ligaments are. They've often got excess, what's called inversion, where the foot inverts too much. And we do something called a Taylor shift test, where you can translate the ankle more out of the ankle joint than you should do. That's called a Taylor shift test. And finally, you can often get too much rotation of the mortise, the talus within the mortise. Those are the 3 tests that we use to assess the individual elements of the lateral ligament complex.
And the problem is that if you've got excessive movement, you can't really change that, can you? And that's where people end up with long-term problems, because what happens is they then sprain their ankle again because it's loose, then it gets looser, and then you've got that classic patient that says, oh, I sprain my ankle about once every 2 weeks.
Yes, so
and that's a problem, isn't it?
You picked up brilliantly on that. So for lack of being treated properly in the first few days, patients then go through a cycle of multiple injuries, injuring and re-injuring and re-injuring their ankle, and they get into that spiral. And that spiral not only causes more and more damage to the ankle ligaments, but they start getting secondary problems in other bits of the ankle and hindfoot. They can get cartilage injuries in the ankle joint. The tendons can be traumatized and get partial tears and stretch out. So it is a spiral, and it's all for the sake of an early assessment with the right person and the right treatment.
Yeah. So actually interesting. We get quite a few emails about the podcast. And it's nice. People will thank us because they'll say, well, I watched your one about meniscal injuries or Achilles ruptures, and I knew what to do straight away. Yeah. So if we go back again, because I think this will be quite useful. Let's say that somebody is watching this and they've been to A&E. They've had an X-ray, which is normal, which we know doesn't rule out a lot of injuries. It doesn't even rule out a fracture. But they can't necessarily get an MRI straight away, which is what we would advise, or an ultrasound. What should they do?
They, like you said, if they've got access to private health insurance, or if they can pay for themselves, they need to get themselves in front of an MSK physician, an orthopaedic surgeon with an interest, a sports medicine physician who can assess them properly clinically, like we've alluded to just now. and get an ultrasound or MRI scan.
But they do need imaging, don't they? Because
100%.
lots of people will go and see a physio. I'm a physio, but I know that even what is a good assessment is limited in getting a structural diagnosis. So you still need some sort of imaging, don't you? Yeah, if you're going to get a proper diagnosis. Correct, But I suppose what we're saying is to prevent that long-term laxity, they need, and you've said it already, they need to immobilize their foot. Now, that doesn't mean put it in a plaster, does it?
No, there are all sorts of fancy boots out there now. So I use a boot called an air cast walking boot. It comes up to the knee. It looks like a sort of slightly lightweight, long ski boot. It's adjustable.
It used to be called the Beckham boot because David Beckham wore a boot for a bit.
Yeah, you're right. Absolutely. It was called the Beckham boot. Yeah. So, there's a cost to them. They're roughly £100, I think.
Amazon now, we have been recommending these. Amazon, you can get them for about £40.
No, really? Okay.
They're not, and they're fine. They're absolutely fine, to be honest.
Okay.
It's comfortable to walk on because with most injuries, we are happy for people to put weight through the leg, aren't we?
Yeah.
But obviously, if it's painful, then the boot will help you walk, but also you may need to use crutches as well for a period of time.
Yeah, so the point to get over to patients is that having one of these boots on is not particularly cumbersome. And actually having your ankle immobilized in a boot is a huge relief because it stops being painful. And then you're not hopping around on crutches or on one leg. You can actually walk
you can
and get around.
Work and...
So it's a massive relief. People just, having hopped in, they're sort of walking out with a boot on and are happy and relieved. They know they've just got to use it for 3 weeks. And then after that, they get reassessed. At that point, we can see that the ligaments are healing up nicely. Then they can get rid of the boot and start a physio program. And then about 6 weeks down the line, the job's done.
Perfect. And we'd just suggest you can put ice on it to help with the swelling. Would you suggest that people take paracetamol, anti-inflammatories?
Just for pain. So there's a bit of a theory that the anti-inflammatories can slow down the healing process.
Particularly if it's a bone.
Yeah. But also in the ligaments of it. Paracetamol is good, but obviously, these things hurt. I've suffered one myself. So have I, as in 1 in 10,000 of us a day have. Wow. So they're very painful. So you take painkillers for the first few days to be nice to yourself. But typically, once you've got the boot on, it's pain that can be managed probably just with paracetamol. Yeah,
absolutely. And also some gentle movement, with the boot off, you can pull your foot up and down. That's not going to cause any real damage to most structures, but it's still at this point, we don't know exactly what's going on. So they come out of the boot at 3 weeks. Hopefully they can then go and see somebody for some further investigation, because even at that point, and people always say to me, how long does a ligament take to heal? Well, we know bones take 4 to 6 weeks. It's quite a linear sort of improvement. But soft tissues, ligaments, tendons, it can really vary, can't it?
Yes, but typically they would have healed sufficiently at around 3 or 4 weeks to be strong enough to come out of the boot. And the healing continues on like an exponential curve. So if you were to measure the strength of the ligaments around 3 or 4 weeks, it would probably be about 60%, something like that. So still
vulnerable.
Yeah, so you've got to be careful. So when you come out of the boot, you can't immediately go off and do what you want to do. You've got to wear flat shoes. You've got to be careful on certain grounds. You've got to avoid any impact or twisting activities. Then by about 6 weeks, you can start sort of upping your game and stop worrying.
Yeah, and we definitely, around 3 or 4 weeks from a physio point of view, would like to see these patients. And generally, you can progress them through a rehabilitation program. But again, I still personally really like to know exactly what structure they've damaged, because obviously that's going to help us, because we might be able to push a patient a bit faster. Or if we don't know exactly what we've done, we're always going to err on the side of caution with these. And hopefully by using a boot, like respecting the injury, people won't end up with long-term laxity or damage. But there is a group, isn't there, that they feel unstable, which means that they feel like they're going to fall over. How does that, obviously you've mentioned how that presents to you, but if you do have a patient with that, just talk us through how you find out the information you need to and what you would do with it.
So for those patients that have damaged their ankle ligaments, they've been immobilized in a boot for 3 or 4 weeks. They've then had physiotherapy, and then they're coming back after 3-6 months and saying the ankle's still unstable, doesn't feel right. I'm examining them and I'm saying, you're right, the ankle still is unstable. And then that small percentage is definitely less than 10%, probably more around 5% of patients. They are offered an operation whereby the ligaments are returned to their normal length and thickness. And this is called a Brostrom repair or a modified Brostrom repair.
And you guys have been doing that for...
Oh, since the 90s.
Yeah, a long time.
It's a very successful, pretty small operation. It's part keyhole and part mini open incision, probably a 2 or 3 centimetre incision over the ankle.
And what do you do in there?
So there's 2 different ways, really. One is where the ligaments are dissected out and restored to their normal length by sort of pants over vesting them. That's one way. That's the original Brostrom repair. And then more and more of surgeons now are using anchors in the bone to help reattach the ligaments back onto the bone by way of these anchors. So it's basically anatomically restoring the ligaments to their normal position, thickness and tension.
Perfect. And just to go back, the patients that should be thinking about getting this done, and I think there's a really key message here, is that if you keep spraining your ankle, in the end, your ligaments are gone. They're not stopping anything, are they? And I find a lot of patients that they go, I keep spraining my ankle. Oh, it's fine. I've been doing it for years. And they sprain it and they go, yeah, it's sore for a couple of days. But I think they sort of think they're coping. But my concern with those patients, and I'm sure you share it, is that every ankle sprain that they keep doing is probably damaging the articular surface of the joint, and that can cause arthritis.
Yeah, so the reasons for restoring the ankle ligaments, doing one of these operations, is to stop the ankle giving way in the short term. And it's an easy operation with a quick recovery, and it's a pretty minor operation without much morbidity, really. But it's also, as you say, and I've alluded to stop the further injuries and the secondary damage. So every time you're going over on your ankle again and again, you're damaging the articular surfaces, you're typically straining the peroneal tendons. And if you were to not have the operation and go down the clock a few years, then you've got a joint which is got early arthritis in it. We can't really reverse that. And you've got chronic tendon damage, which we have to repair. So they're looking at a bigger operation with a poorer outcome. And
I think that's key, isn't it? Because if, from your point of view, if you've got an ankle that is unstable, so it's giving way, but you've also got a damaged joint, you can repair the ligament, but then you've still got a damaged joint.
Yes. So there are certain sort of keyhole surgery or arthroscopic procedures we can do to minimize that damage, but it's very hard to get it back to how it was before the first ankle injury.
So although we don't want to necessarily advocate that, everybody goes for surgery, there is definitely a group that should consider it before they do any long-term damage to their joint. So you talked about the recovery from the Brostrom repair. How long, if I was a tennis player or a rugby player or something like that, how long would I be out for?
So it's about a 40-minute operation, typically.
Day case?
Day case. You leave
general anaesthetic?
General anaesthetic with a regional block.
Right. What does that mean?
A regional block means a bit like the injection you get in your mouth when you go to see the dentist. The ankle and foot is numbed.
Yeah.
So when you leave hospital, the ankle normally feels numb and a bit pins and needly.
Yeah.
That's normally worn off after 24 hours. But you're pretty much manageable pain. You leave hospital the same day in one of those aircast boots.
Yeah.
I personally, my patients use that boot for 3 or 4 weeks. The stitches come out at 2 weeks. After 3 or 4 weeks, the boot's discarded, and then it's over to you guys for physio.
Yeah.
Then typically by about 6 weeks. So when the boot comes off after 3 or 4 weeks, it's a range of movement exercises. It's swimming, it's cycling, it's non-impact stuff.
Yeah.
And then by about 6 weeks, they can start doing straight line running.
Yeah.
And if you want to play Wimbledon, it's probably about 12 weeks, I would say.
About 3 months, I think that seems fair. And certainly one thing from a physio point of view is it's so important to have physio after, because as you all know, because obviously you're repairing everything, people get a bit scared of moving it. And if they end up with a stiff ankle, they can be a nightmare, can't they?
But the advantage of this Brostrom repair is the chance of you being stiff afterwards are almost zero.
Yeah, yeah.
I can count on the fingers of one hand the number of patients who I had to do something else for stiffness.
Yeah. So I've got one patient but that was somebody that was scared of moving. We didn't see them for 6 weeks.
Right. Okay.
And it just felt like it wasn't one of yours, Simon.
Yeah. The only other thing I would mention is that sometimes when we do these MRI scans, after the x-rays have shown there's no fracture, the MRI scans will sometimes pick up in about 5% of patients injuries that actually do require early surgical intervention.
So give us an example of that, because that's quite key.
Yeah, the classic example would be a talar dome injury.
Yeah.
So sometimes you've broken off a piece of bone and cartilage inside the middle of the ankle joint.
And that's where the bones actually go together.
And that, if there's a loose fragment there or an unstable fragment, that will require keyhole surgery to resolve that. Sometimes there are fractures that might need potentially intervention. And sometimes there are bad tendon injuries that have been torn and they need repair. And, those need to be fixed quickly. So,
and certainly with a tendon, the sooner the better, I assume, in terms of the outcome from surgery.
Yeah.
Yeah.
And, randomly, also these MRI scans will pick up Achilles tendon injuries that no one knew about as well. So everyone thought it was a standard inversion injury with a ligament injury, but now and again it picks up a Achilles tendon injury that no one knew about.
Yeah. So I suppose the key messages is that, x-rays don't always show every break. That period of immobilization at the beginning is very important. And I actually saw a patient yesterday and they did the classic, it was fine after a couple of days. So I just started walking on it.
Yeah.
And obviously, it's fine walking on it, but actually if you ever want to run on it or something like that, you need a lot more, it tests the ankle out a lot more, doesn't it? So immobilization is really important. And then I think what we're saying is that if you've still got pain when you come out that boot at 2 to 3 weeks, what we are saying is that getting some sort of MRI or diagnostic ultrasound is really important.
Yeah.
And I suppose the problem at the moment, particularly with NHS waiting lists, unless you can afford private healthcare, it can be quite difficult to get that input at the right time, which then means you end up with a delayed diagnosis. And that's certainly where we see a lot of the problems starting, isn't it?
Yeah.
Brilliant. Well, thank you very much, Simon.
Thanks, Chris. Good to see you again.